Good day. Welcome to the International Myeloma Foundation's Regional Community Workshop. My name is Kelly Cox, and I'm the Senior Director of Support Groups and Regional Community Workshops. I've been involved with the IMF for 21 years and completely believe in every program that we put on as working with these great doctors and nurses. Next slide, please. Now, we want to tell you on a Saturday, especially before Thanksgiving, while you're shopping, trying to figure out how to do dinner or doing dinner that takes a week to do, I am grateful, as well as everyone else is grateful that you're participating today. This is set up for the Pacific Northwest states, but I know we have people from around the country, so we certainly should have some great questions. Next slide. You can get any of our booklets, our series, our webinars like this, on our website at myeloma.org. These are just a few of the periodicals that we have, the programs, and things that we do in the future. We'd like you to keep an eye out for Best of ASH this year, where we'll be having a program mid-December discussing what happened at ASH for you as a patient. ASH is the American Society of Hematology. Next slide, please. We are very grateful to our sponsors here at the International Myeloma Foundation. We got a new sponsor, AbbVie. Karyopharm has been with us for a bit. Same with Amgen, GSK, Bristol Myers Squibb, Janssen, and Takeda, all very dedicated to the IMF cause. And personally, I'm grateful, as well as the IMF is. Next slide, please. When you see this come up, I want to tell you how important audience Q&A with the panel is. You'll see on your screen, it says, welcome to Q&A, and you can send it anonymously or with your first name. Don't get too deep into the details of your treatment because it's hard to answer those questions. So pick one topic that you're having difficult with, or you need confirmation with, or something of that nature. But keep your questions to small minimums because we have a lot coming on today. Next slide, please. Now, if your technical issues arise, please use the Q&A to send questions to our support team. They will reach out to you and help you get it straightened out if at all possible. Some questions are, there's a lag in the audio. Can someone assist me? That's just an example. That doesn't happen too often. Next slide. Feedback survey. Listen, none of this matters if you don't take time to give us feedback, because we guide our programs and mission upon feedback of patients like yourself, caregivers, parents, grandparents, family members, to say, this is good, this was bad, you sort of met my expectations, you met my expectations. Take the time. It's 5 minutes. It won't kill you. We need this information from you. Next slide, please. Okay, now we're going to be getting into this. As a follow-up to today's workshop, I want you to know that if you didn't get the information or you feel like you missed something, you'll be able to go back and go to that program on our website at myeloma.org and listen to it at your pace. The slides will be there, as well as the voiceover, excuse me, that's an old term for me. And you'll see the doctors talk about things, and they will answer questions that you might have proposed. So do make note that you can see this again at your own convenience, as well as any of the other 10 programs, 20 doctors, 10 nurses that I put on this year, being the 139th RCW that I've done. It's fantastic. I've done this for 20 years, 21 years. It's amazing to me. Next slide. Here we are. We're going to get into the meat and guts of things. Welcome. I'm done. We can just move on from there. 10:05, we got Craig Cole coming up, Michigan State University. Dr. Cole and I have known each other for many years, and he's a great speaker. We'll go into question and answers with the panel, and then we go into our new program, which is meditation and stretch break. It's a wellness break. So while some of you might be getting coffee or something, some of you might want to just relax, breathe, stretch, and get ready for the second half. Next one, relapse therapy and clinical trials. Dr. Kirshon, MD, City of Hope Comprehensive Cancer Center. I've worked with her for many years, and she's one of the best in the world of myeloma. Oh, and a dear friend of mine, Sandra Rome, how to manage myeloma symptoms and side effects. Don't leave. Come back and listen to this, because this is going to help you. And then we'll have a question and answer with panel and try to get you out of here soon. But just get online, get into this, get your pencils ready, and we're going to be going on to the next presentation right now. Dr. Cole, take it over for me. I appreciate you doing this today.
Oh, well, I greatly appreciate being invited. And again, I think this is a fantastic program. Every time Kelly says, can you talk to the IMF? I am right there because I love this program. And my patients tell me how much they really enjoy it.
Thanks, Greg. That means a lot to me.
Oh, absolutely. So we're going to talk about myeloma 101 and upfront therapy. So today's discussion, we'll talk about what is myeloma, how common is it, the spectrum of plasma cell disorders. We'll talk about something that's really important. A point of empowerment is knowing your labs and knowing what labs to follow when you have myeloma. We'll talk about staging and risk stratification, talk about how some of these therapies work. Then we'll talk about upfront strategies for myeloma, including induction, transplant, maintenance, bone support. And then we'll talk about the new stuff, including the exciting area of 4-drug induction therapy, and then perspectives on survival. So to level set, what is myeloma? So inside the bone marrow, the spongy stuff inside the bone, there are plasma cells. And plasma cells are part of the immune system, and they produce proteins called antibodies, which help us fight infection. But just like any other cell in the body, if those plasma cells in the bone marrow become mutated in cancer cells, then those are myeloma cells. And we call those multiple myeloma cells or malignant plasma cells. And they produce excessive amounts of antibody that can be detected in the bloodstream that we'll talk about in a bit. And those are the monoclonal proteins, or we shorten it as the M protein. That tells us how many plasma cells, helps us tell how many plasma cells are actually in the bone marrow. So because myeloma is a malignancy of those plasma cells and inside the bone marrow, it can actually crowd out the normal production of blood inside the bone marrow, causing low blood counts or anemia. Also, those plasma cells love being inside the bone, and they actually take over parts of the bone and cause bone destruction. And they can cause what we call lytic lesions or damage or weakened areas inside the bone. And also, while those plasma cells are damaging the bone, they can release excessive amount of calcium inside the blood, raising the blood calcium levels, which can make people feel sick. Those proteins, those M proteins that are produced by the plasma cells can get trapped in the kidney, especially little fragments of those proteins called the light chains, which can clog up the kidney, the filtering part of the kidney, causing kidney damage. And the mnemonic that we use to talk about the signs and symptoms of myeloma are the Crab criteria, with C being high calcium, R being kidney damage or what we call renal failure, anemia with those low red blood counts, and bone destruction being B. So what are some of those symptoms? Well, those low blood counts, which occur very frequently, the low red blood count can cause people to have anemia, which can cause weakness and fatigue. When those proteins get trapped in the kidney and cause kidney damage, in over about half of patients with myeloma, that can cause weakness and fatigue. When those plasma cells go to the bone and cause bone destruction, which is very common in myeloma, it can lead to fractures and pain. And of course, pain can lead to fatigue. And then those high levels of calcium that we talked about can cause patients to have loss of appetite, confusion, fatigue, and excessive urination. And so again, with those Crab criteria, the major things that we use to help us diagnose multiple myeloma. But one thing to note is about 10 to 20 patients with newly diagnosed myeloma may not have any symptoms at all. And we'll talk about that in a bit. So this is the second most common blood cancer behind the lymphomas, the lymph node cancers. Last year, about 34, almost 35,000 cases diagnosed of myeloma. We'll get back to this, but there are almost 140,000 people currently living with multiple myeloma in 2021. It's most frequently diagnosed in adults. We rarely see it in people under the age of 30, never see it in children. So it's a cancer of adults. And it has an interesting increased incidence in people of African descent. So just not African Americans, but people of African descent around the world have a higher incidence than whites. And there's an active area of research to see why that is, but we still don't quite know why. So all myeloma begins with the monoclonal gammopathy of uncertain significance, where you have a small number of those mutated plasma cells, a small number of that monoclonal protein, and of course, no symptoms. And that has a low risk. MGUS is very common. About 4% of people over age 50 have MGUS, but it's a very low risk of progression to multiple myeloma. When you have more plasma cells in the bone marrow, more of that M protein, but again, no symptoms, then we call that smoldering myeloma, where it's smoldering underneath the waves of the disease. And that has a higher risk because those more plasma cells are more mutated and therefore are closer to multiple myeloma. And then there's what we call high-risk smoldering myeloma, where the M protein is higher, the number of plasma cells is higher, and the fragments of protein, those free light chains, are higher. And especially when you see the hemoglobin dropping down and that protein going up, when there are dynamic changes in the smoldering myeloma, we call that high-risk myeloma, which has a much higher risk of becoming active myeloma. And then there's true myeloma. Again, when you have malignant plasma cells seen on a biopsy, usually a bone marrow biopsy, and one of those symptoms and signs that we talked about with the crab pneumonic. And about in 2014 or 15, we realized that patients that have very high numbers of plasma cells in their bone marrow, greater than 60% plasma cells, or if they're free light chain, the little fragments of that M protein are very high, or when we use a sensitive scan to pick up a more than one lytic lesion, those patients have a 90% chance of having symptomatic painful myeloma. So we treat those patients, and that's considered now multiple myeloma. For MGUS, we usually observe in clinical trials. Smoldering is becoming a very active area of clinical trials and observation. Those high risk, ultra high risk smoldering, well, there are some, for some patients, they could consider treatment. We recommend clinical trials or very close observation. And of course, true myeloma, either with the SLIM criteria or the CRAB criteria, we ask patients to either enter clinical trials or upfront therapy that I'll talk about in a bit. So it's important to know your labs. Again, as I mentioned before, a point of empowerment. So the CBC tells you what the red blood count is. The hemoglobin is the main way that we determine what the red blood count is, along with the white blood cells help fight infection and the platelets help make blood clots. The comprehensive panel is another important lab. That tells us about the calcium that we mentioned before in that CRAB criteria. The creatinine, which is a measure of kidney function that are in that CRAB. And the alkaline phosphatase, which can give us an idea of bone status, as well as looking at the rest of the electrolytes and can help us determine the extent of disease. Now, there are two tests that we use for staging purposes. The beta-2 microglobulin is this little protein that sits on plasma cells and is shed into the bloodstream and excreted in the urine. And the higher the beta-2 microglobulin either tells you how many plasma cells are in the body, or if the kidney function is low, since that protein is released by is excreted by the kidney. And the LDH is another test that we use for staging purposes, because when those myeloma cells are dividing very quickly, they release that chemical in the bloodstream, that lactate dehydrogenase, and can give us an idea of what the biology of the myeloma is doing. And then the test that tells how much myeloma there is. The SPEP is the main test that we use to detect how much myeloma protein there is. And I'll show you a little cartoon about that in a bit. The immunofixation tells us the type of protein, if it's IgG, IgA, or kappa, or lambda. And then the free light chain assay, because some patients, I'll show you in a bit, won't produce those intact proteins, will produce only free light chains. And that gives us an idea of how much myeloma there is. And I think these days, the urine protein electrophoresis and the 24-hour urine has become more of a research clinical trial test. It's what we use for for almost 130 years to tell us about myeloma. But the urine test has kind of gone the way of the dinosaur for the most part. The big three tests are the SPAP, the immunofixation, and the free light chain assay. So the SPAP tells us how much myeloma there is. So normally, if you graph out the different types of protein in the blood, albumin is the most common protein in the blood. And over there in the gamma regions where those antibodies hang out. And we produce lots of different types of antibodies. So there's a broad hump on that side. However, if you have myeloma, that gamma region is distorted by lots and lots of that protein being shed by those myeloma cells. And that tells us that's the M protein. And the area under the curve is exactly the number of monoclonal protein, which is equivalent to the number of plasma cells in the bone marrow. So you get your bone marrow biopsy, it tells you got 30% myeloma cells, and then that M protein tells you is an equivalent to that. So you don't have to get a bone marrow biopsy every month. You can just check the M protein. And then as patients get treatment for their myeloma, and a little treatment, there we are. But a little treatment for their myeloma, again, it kills the myeloma cells. And instead of doing a bone marrow biopsy to see if it worked, we just check the M protein. So if the M protein goes down, then you know it's time to celebrate that you're responding to therapy. Again, about 12% of patients with myeloma will only produce those fragments of protein called the free light chains. And normally we produce very small numbers of free light chain in our bloodstream that can be detected on the free light chain assay. However, and the ratio between the kappa and lambda is about 1:1. And again, we normally produce that in very low amounts. However, if you have myeloma, you'll have very high numbers of kappa or lambda protein. Again, about 12% of myeloma patients will have that. It'll suppress the uninvolved light chain. So if you have kappa myeloma, your lambda light chain will be low, and the ratio will be much higher. And then when you receive treatment, again, it reduces the number of plasma cells down. It reduces that kappa light chain down or lambda light chain. The other one is restored. And then the ratio goes back to 1, and you know when to celebrate. So about 80% of myeloma patients, the SPAP will be the main test for the M protein. Again, IgG, kappa, or lambda, that's the light chains that are stuck to those those heavy chain proteins. But again, about 18% of myeloma patients will only produce the fragments of light chains that will be detected on the free light chain assay that I just mentioned. And about 3% of patients, about 2% of patients, the myeloma cells are so mutated, they forget how to make any protein at all. And therefore, we use usually imaging studies to follow those patients along. So how we meet the diagnosis? Well, we check off those CRAB criteria. Conventional x-rays we've been using for about 100 years to detect myeloma. But the PET scan has a more recent test that is much more accurate. And this is a patient of mine from a long time ago where we did an x-ray, and you can see the holes in the skull of this patient. That didn't hurt her, but it was easy to detect her myeloma by those holes in the bones. A much more sensitive test is the PET scan, which has a immunoradio tracer or a sugar chain tracer that tells you the metabolically active areas inside the body, and again is a much more sensitive test to pick up myeloma. And these days, we use a bone marrow biopsy to confirm the diagnosis, as well as to help us tell what mutations happened. And if you have more than 10% of plasma cells at the bone marrow with either that CRAB or some CRAB criteria, then you meet the diagnosis of multiple myeloma. So how do we figure out what happened to cause the myeloma? Well, we can look at those mutations that occurred. So we get those plasma cells doing the bone marrow biopsy, and we look at the chromosomes, the genes inside those cells, to see what went wrong, because it helps us tell about staging. And the main test that we look at is the FISH. And you can see in that plasma cell in the middle, usually we have 2 chromosomes, one for mom, one for dad. But in this patient, she has 3, chromosomes, an extra chromosome that occurred in that fish cytogenetics that told us kind of what went wrong inside the plasma cells a long time ago. She wasn't born with these 3 chromosomes. It just happens that her myeloma, her plasma cells mutated, ended up with 3 chromosomes, and now we know what's going on. But what's becoming more and more common is using next generation sequencing to look at the individual genes that may be involved in myeloma progression. So with the information we get from the fish, then we can put patients in different risk categories. So patients that have high-risk myeloma, they have very specific mutations that happen inside their plasma cells, where the 17th chromosome only has 1 copy, or deletion of the 17th chromosome, or they have gains of the 1st chromosome, or translocations where the 4 and 14th chromosome is stuck together, the 14th and 16th chromosome is stuck together, and on NG or 1420, and on that next generation sequencing, you can see mutations in P53, which is an important gene to keep cancer cells under control. Without that P53 gene, either in chromosome 11 or if it's mutated, then the myeloma cells aren't kept in check and become more aggressive. Standard risk myeloma is when either the chromosome analysis is normal, or you have more than 1 pair, or you have the translocation of the 11th and 14th chromosome, or 6th and 14th chromosome. Standard risk myeloma, most patients that have standard risk myeloma, a bit easier to treat and to maintain remissions and responses. High risk myeloma, a bit more difficult, and can in some cases be quite a bit more difficult to maintain those responses for long periods of time. And so we use all those tests that I mentioned in order to assign stage. If you have low numbers of plasma cells inside the bone marrow, that beta-2 microglobulin is low, and you're not producing lots of plasma cells, the LDH is normal, and you don't have any high-risk cytogenetics, that's stage 1. If you have high amounts of plasma cells in the bone marrow, those plasma cells are dividing quickly, and you have high-risk cytogenetics, then that's stage 3. And things that don't fit, where you have to mix and match the stage 1 and stage 3, patients assigned to stage 2 myeloma. And that actually comes in very handy. We'll talk about that in a second. So how do we treat myeloma in 2022? We use science to treat myeloma. We don't use much chemotherapy. We only use chemotherapy just once in induction therapy, but we use science. The immunomodulatory drugs, thalidomide, Revlimid, and Pomalyst, we'll talk about that in a bit. The proteasome inhibitors, Velcade and Ninlaro, and Kyprolis, and then the antibody drugs, Darzalex, Sarlissa, and Implicity. And those are the main science drugs. So we have lots of new therapies that have also come out that are used more in the relapse setting, including teclistamab was just approved just a few weeks ago for relapse refractory myeloma. So how does Revlimid and the IMiDs work? It uses science. It inhibits DNA synthesis to a small degree, so the cells have a difficult time reproducing. But one thing that it does is it slightly inhibits blood vessel growth. So it inhibits VEGF, vascular endothelial growth factor. If you don't have blood vessels to feed the myeloma cells, they starve to death and die. So that's one slight way that it works. One of the main ways that Revlimid and Pomalyst and thalidomide work is by inhibiting adhesion of those bone marrow, of those plasma cells to the bone marrow stromal cells. The reason that myeloma is in the bone marrow to begin with is it needs those bone marrow stromal cells in order to proliferate and reproduce. So if you break that adhesion, those myeloma cells can't live without their bone marrow stromal cells and they die. So they break that adhesion that the myeloma cells are dependent upon. It also starves in the death of the main cytokines, the main chemicals they need to grow, proliferate, and help avoid death from chemotherapy. or from therapy, I'm sorry. And so starving them of their growth factors kills them. And then one thing that actually was discovered late when these drugs came out is that it actually harvests your own immune system, your own T cells to attack the myeloma cell. That was an unexpected way that these drugs work, but it is amazing that your immune system that was previously ignoring the myeloma cell, with these drugs, they actually attack the myeloma cell and kill it. So it has a multimodal mechanism of action, which led to thalidomide initially being used in the 90s, Revlimid then being proved in 2006, a more potent version of thalidomide without a lot of the side effects, then Pomalyst coming out a few years later for relapsed refractory myeloma. Iberdomide is the newest class of the IMiDs currently in clinical trials, and then the CELMoDs, the designer IMiDs that are currently in clinical trials and are very, very potent compared to the drugs that we're using now. What about those proteasome inhibitors that I mentioned? Well, myeloma cells produce lots of protein. They produce lots of waste. We talked about that M protein. That produces a lot of waste. And the proteasome is a trash compactor, the waste management system inside those plasma cells. So when those myeloma cells produce these functional proteins, like the receptors and the adhesion proteins and those monoclonal proteins, when those proteins get old, they then get transferred to the proteasome. And inside the proteasome, they get torn up and it's like the trash compactor and excreted by the cell. So that's why these myeloma cells are packed full of proteasomes in order to control the waste management. However, if you inhibit the proteasome, if you put a diaper in the toilet, well, I shouldn't have mentioned that, but I did anyway. If you put a diaper in the toilet, then those proteins build up inside the myeloma cell, because remember, they produce so much protein and it kills it. They pop wide open. And so the proteasome inhibitors, very potent drugs. Velcade was first out in 2003, now upfront therapy for myeloma. Fantastic response rates and still to this day in combination therapy. Carfilzomib is a reversible proteasome inhibitor. So instead of putting a diaper in the toilet, that's like putting cement in the toilet. The proteasome is permanently turned off. And again, those waste products build up inside the myeloma cell. And then Laro is an oral version of Velcade. Then the final drug I want to talk about how it works are the immune therapies. So each cell in your body has a certain number of surface proteins which tell you what cell is which. Myeloma cells are no different. They have proteins sitting on their cells which help tell which cell is which. And they have a certain number of proteins, including SLAM7, GPRC5, FCRH5, CD38, and BCMA, which identify plasma cells as plasma cells. Well, your body's not making any antibodies against this. That's why you have myeloma. However, the laboratory has built in therapies which specifically find those myeloma cells and kill them. Elotuzumab is an antibody built against SLAM7. Daratumumab, isatuximab are built against CD38. And then we have a number of incredible therapies against BCMA, including, again, the CAR T therapies and most recently belantamab and teclistamab that are all directed towards. But let's take a look at those elotuzumab and daratumumab and isatuximab. So here's a plasma cell. I talked about those surface proteins that are on top of them. And when those drugs, when those man-made or manufactured antibodies attach to the myeloma cell, it gets your own immune system, the natural killer cells, to attack the myeloma cell and destroy it. They see the antibody, anything that has an antibody attached to it needs to be destroyed. And so when it attaches the myeloma cell, they're dead. Also, cytotoxic macrophages, the cleanup crew of the body, when those antibodies attach to myeloma cells, those macrophages go in, eat them up, and engage in hand-to-hand combat with the myeloma cell. Also, there's an ancient part of our immune system called complement, which attaches to the antibody. And when complement attaches to the antibody, it bores holes in anything that has antibody attached to it, which then the myeloma cell has a bunch of holes in it and leaks and dies. Also, by cross-linking those surface proteins, it actually short circuits myeloma cells, which kill them. And then finally, when myeloma cells have antibody attached to it, again, those bone marrow stromal cells have no tolerance for those myeloma cells having antibody attached to it, and it kicked them off, and again, they starve to death. So that gives you an idea of the tools of the trade. The IMiDs that we talked about were Revlimid being our main IMiD in upfront therapy, the proteasome inhibitors, including Velcade and Kyprolis as upfront therapy. We do use chemotherapy for upfront therapy for myeloma, usually with stem cell transplant, we'll talk about in a bit. We're still dependent on steroids to help augment the effect of those other drugs in killing myeloma cells. And then we talked about the monoclonal antibodies that we use for upfront therapy. So there are lots of different induction therapies that are available for myeloma patients when they're first diagnosed, and dependent on performance status, how you're feeling, other medical problems that you have. There's a list of different medications, but VRD or RVD and DARA RVD are two of the main ones that we're using now. Then there's consolidation with stem cell transplant or continuing on the same therapy, and then we have maintenance therapy that we'll talk in a bit. To maintain those good responses that are cheap with induction and consolidation. And then there are all of the new therapies for relapse therapy that we'll talk about a bit later. So what do we do when we diagnose somebody? Well, when we diagnose somebody, they're either not a transplant candidate because they have other medical problems which preclude getting a stem cell transplant. If they have high risk, remember we talked about stage and we talked about cytogenetic risk with those fish. They have high risk and they're not a transplant candidate. Then we either use the 3-drug regimen of VRD or sometimes DARA, that antibody plus Revlimid and Dex for about a year, followed by maintenance. If you're standard risk, then sometimes we'll use a light doses of RVD or DARA RD, again, followed by maintenance therapy. If someone's a transplant candidate and they have high-risk disease, then we really think about using those 4-drug induction regimens followed by early transplant. And I'll show you how important transplant is for high-risk patients, really important for all patients, but especially the high-risk patients. In standard-risk patients, they get DARA RVD or RVD followed by auto transplant, and everyone gets maintenance therapy. Sometimes there is studies that show you can delay transplant if you have other things going on, and there's no change in overall survival. But our preferred is to get your induction therapy, get the myeloma under control, go to stem cell transplant, and then go right to maintenance is the usual path. Because what we want to do is drive that disease down as low as we can possibly get it. That when patients are first diagnosed with myeloma, the iceberg model, the myeloma is very obvious when patients are diagnosed, that they have high M proteins, they're anemic, and they feel bad. But as we go through therapy, then we want to reduce the myeloma cells down. And therapy will then drive the disease underneath the waves, so it's not obvious that they have myeloma. When that M protein divides in half, when you go from an M protein of 3 to 1.5, that's a partial response. If it goes down to a very good partial response, 90% of the myeloma has responded. Again, you know when to celebrate. And then a complete response is when there are no proteins seen on the blood test, no SPAP or free light chain testing. And again, we want to drive the disease as low as we can get it. There are even tests called minimum residual disease testing that can get even lower numbers can detect even lower numbers of plasma cells. So again, we want to drive the disease down as low as we can get it. Well, how do we do that? Well, stem cell transplant helps. And so I don't know much about boxing, to be honest with you, but I do know that when you're using RVD or DARA RVD, it's like using the right hook. You punch the guy a bunch of times with the right hook, but if you want to knock him out, use the left hook. The myeloma is not expecting the chemotherapy of a stem cell transplant. Use that left hook, knock the myeloma out, then use maintenance therapy to stand on the bad guy so he doesn't get up for a long time. There's a study that was recently published called the Determination Study, which is a very large study that took place in the United States to tell us how important is transplant. So in this study, they got patients, newly diagnosed patients. They either received, all patients received RVD, the 3-drug regimen. Everyone got their stem cells collected, but only half the group went to transplant. The other half of the group underwent observation. They then got consolidation and then went to maintenance. So, and what we're looking for is, does transplant prolong the time that it takes to relapse with multiple myeloma? And after 6 years, we got an idea of what's going on. So patients that underwent transplant, when you look at toxicity, so grade 3 and 4 toxicities, so some bad side effects, transplant wins for side effects. However, those side effects take place in the hospital. That's why people are in the hospital or under close observation when they get a stem cell transplant, because we know all about how to handle those toxicities, because we've been doing transplant for over 20, 30 years now. So yes, it's more toxic, but we know how to manage those toxicities. But when you look at how long it takes to relapse, transplant wins. Longer time in that response that you've worked so hard at by getting a transplant. That is really accentuated for those high-risk patients. Again, it's harder to maintain those responses with high-risk patients. And so there's a clear benefit of transplanting and doing that left hook of chemotherapy for high-risk patients. However, overall survival, transplant versus no transplant, is the same, because you have so many good therapies when patients relapse, but it's better to maintain those responses as long as you can. And when you look at deep responses, again, transplant wins. And you look at MRD, those deepest responses, transplant wins. And so at a median of 76 months, the risk of progression or death associated with the study was higher in the patients that got RVD alone than those that underwent transplant. When my patient said, well, how much is this going to impact my quality of life? Well, when you look, here's the blue line is the patients that got RVD alone, and the red line is the patients that got transplanted. So yeah, you feel kind of crummy, after the transplant, but you recover from it. And when you recover actually better than what you started. In fact, everyone was better than they started. But again, you had a longer period of remission, and the disease is forced down lower. What do we do after transplant? Well, there's a study that looked at that, where they got newly diagnosed patients, they underwent transplant, they either got a second transplant, more therapy, RVD therapy, or they went directly to Rev maintenance, and everybody eventually went to Rev maintenance. But between those 3 arms, there was no difference in time to relapse in those 3 arms. So it's as easy as to go straight to Rev maintenance. There may be a benefit to TAM transplants with patients with high-risk disease. There are several studies that have shown that randomized trials way back in the day, when we didn't know that maintenance therapy was as good as it is, that randomized patients between either no maintenance or maintenance after transplant. And again, it showed a clear improvement in progression-free survival and a bit of overall survival by doing maintenance therapy, low-dose Revlimid or Velcade, post-transplant. The last thing in the way of induction therapy, and probably one of the most important things, is strengthening the bones. We get those really good responses, but we want the bones to heal, because myeloma can weaken the bones. We want to make those bones strong again. And so we use permitinate or Zometa or Xgeva for at least 2 years after patients, when they're first diagnosed. Irregardless if they have bone disease that we see or we don't see, we know patients benefit from bone strengtheners, as well as taking vitamin D and calcium supplements to help the bone healing. And for patients that are undergoing pain, we have a number of different people that we involve with, including orthopedic surgery and interventional radiology to help with pain control. So briefly, I talk about some of the new stuff that's happening. We've been using RVD therapy as induction therapy for a long time for myeloma. There was recently a study that was published by Pete Voorhees, where they got newly diagnosed patients with myeloma and either gave them RVD, the standard of care, super good therapy for myeloma, been doing that for years, or they gave them Dara-RVD. They added on that antibody that we talked about. And everyone underwent stem cell transplant. They then got consolidation and maintenance, either with Dara-Rev for a couple of years, and then Rev indefinitely, or just Revlimid alone. So did it help to add on the daratumumab? Well, when you look at RVD responses, I mean, fantastic, 91% overall response rates. And look at those deep responses. 73% had VGPR, a 90% reduction in myeloma. 42% had a complete response, or when the proteins are gone. But look what happened when you had the Dara on. More patients with a VGPR, those deeper responses, more patients with complete responses. So again, response rate was high, overall response rate was higher, but more of those deep responses where the iceberg was really shrunk down to an ice cube. When you added on, and when you got to the end of the study, when patients after they were on maintenance, again, even deeper responses. So, and that really resulted in improvements in progression-free survival on the Dara-RVD arm, which really has resulted in it being the new standard of care. I know at our Karmanos and at Michigan State, that's really been our go-to induction therapy for myeloma, for newly diagnosed myeloma patients. And there are a number of studies that are ongoing and are going to result very soon, looking at 4-drug induction therapy. It's a busy slide, but look at those overall response rates, 99, 95, 100%. 100%. If you'd have asked me 15 years ago, was it possible to have 100% response rate in myeloma? I would say that is insane. We're doing it today. Which is so exciting. So it's important to know your goals of therapy, because some patients don't want their myeloma. They don't need their myeloma to be in a complete remission or to have shrunk down to an ice cube. And so know your goals of therapy so you know which therapy to pick. Know how to read your M protein level, because the more myeloma cells you have equals the amount of M protein. So you know when to celebrate when the myeloma responds. Know your risk and stage of myeloma, a point of empowerment to know what's going on with your disease, and know your therapy options. Know when you respond. When that myeloma and M protein shrink down, you know when to celebrate and get some ice cream. So know and talk to your doctor about what your response is. Know your side effects and know who you can report them to, because we really want to know. We've been doing this a long time, so we know how to treat some of those side effects. Know who's on your team and obtain second opinions, because myeloma care is complicated in 2022. So always get a second opinion so you can hear it a second time. And know about clinical trials. The pointy end of myeloma therapy in 2022 and 2023 are clinical trials. Be informed and empowered. And here's my favorite slide. So now with these 3-drug induction therapies, our response rates are 98, 99, 100%. Incredible. We have 32 new drugs and indications approved by the FDA since 2015. No other cancer has kept pace with that. With novel therapies, survival has improved dramatically. When I had hair and I had maybe bell bottoms, not bell bottoms, but I was less fashionably conscious, the myeloma survival was much shorter, so about 5 years. Now it's over 8 years, and I don't even know, because we have all these new therapies coming out. The 10-year relative survival rate has doubled in the past 20 years. And when you look at the number of patients living with myeloma in 2004, it's about 54,000 patients. But remember those numbers I told you at the beginning, that over the years, the number of myeloma patients has been increasing. That is not because the incidence is rising so much. It's because people are surviving this disease more than ever. Look at that jump. Again, 54,000 patients in 2004 when we only had 3 drugs that I talked about. Now we have 32, and now the survival is so much better. So myeloma may not be curable yet. We are working like crazy to make it curable, but it's survivable now. And thank you very much.
Well, thank you, Craig. Your talks always are inspirational for me, especially when you mention ice cream. I'm going to get some ice cream after that. There's a friend of mine that owns an ice cream, or like a vending kind of thing, and he brings ice cream from Santa Barbara, from McConnell's. I tell you, I stay there and I have 2 scoops. It's so good. So I tell every patient, get ice cream. Makes you smile.
Ice cream makes you smile.
You smile when the doctor's there. It's all a good thing. Just can't pass on it. All right, we're going to go into some questions here. Let me look at the chat, see if anyone's awake yet. Rob, do you see any questions right now? I don't see any yet. I think it's early for some people and late for you on the, there's no questions right now? Okay, so let's do this. Is there anything else you'd like to add, Craig, or Dr. Kirshner, would you like to add anything with Craig's talk or have a discussion a little bit?
You know, one thing, a couple things that I get asked about quite a bit is what what if you're not a transplant candidate? I guess there are 2 things. One, if you're a transplant candidate, is there good therapy for me? And we use, there's a study that looked at, in fact, there have been several studies that have looked at, what are good therapies if you can't undergo a therapy, and really using that daratumumab, Revlimid, Dex induction therapy is very good therapy. Definitely our preferred is to use stem cell transplant, the right, and left hook for the myeloma, but they're very good therapies that are available for patients who can't undergo stem cell transplant. Age is not a discriminator for transplant. So, if I have patients that run, they're in their 80s and they jog 2 miles a day, that is definitely someone that could undergo stem cell transplant. I have 40-year-olds that have really bad heart disease and really bad lung disease that make them ineligible to transplant. So it's not so much your age is a discriminator, but other medical problems that may preclude getting that high dose of chemotherapy. The other thing that I get questions about are randomized trials. I know that we're going to talk about clinical trials in a bit, but I mentioned I think 3 randomized trials, and each one of those randomized trials, patients either got the best therapy that is available, which was Revlimid, RVD in the Griffin trial, or they got RVD plus transplant, or they got the experimental arm, for determination that was not going to stem cell transplant. And for Griffin, that was the addition of daratumumab. So there shouldn't be any fear of randomization, of being on a clinical trial and being randomized in 2022, that you will get the best available therapy that is on the study, or you get the best available therapy plus something else.
Sure.
And so so you're going to get good therapy no matter what. And the randomized trials that I showed you, everyone got good stuff. So those are the 2 points I wanted to throw.
Dr. Kirshner, would you like to add anything to the talk this morning?
Well, I think Craig did an incredible job and certainly made my life in regards to my talk easy because he's covered all the major drugs. I do want to add 2 things. Number 1, in regards to the comments on non-transplant eligible candidates, we now actually have a trial that's going to open. It's probably already open in Europe. The Majestic 7 trial, which is going to look at some of the newest agents. So what I'll be talking about in my talk is teclistamab, a bispecific T-cell antibody that's approved for relapsed myeloma after 4 lines of therapy. But Majestic 7 is going to use teclistamab plus lenalidomide, comparing it to the standard of care of daratumumab lendex in newly diagnosed myeloma patients who are either not eligible for a transplant or not intended for a transplant. So I think that will be a very exciting trial of trying to use these, newest therapies in the upfront setting. In the transplant eligible population, there's also another very exciting trial, CARTITUDE-6, which is going to be a US and European trial. It's run by the European Myeloma Network. And it's going to answer the question I think we've all been trying to answer is, what is the role of CAR T cells in the newly diagnosed patient, and will CAR T cells be better than autologous transplant in the upfront setting? So this trial is going to use a quadruple induction that Dr. Cole prescribed, followed by randomization to either autologous transplant or to CAR T cells. So I think that's an incredibly exciting trial as well.
Amazing to hear what you just said. And Craig saying 32 new drugs since 2015. That it just blows me away from being in this. We have a couple of questions. Neuropathy and slide this down, neuropathy and secondary cancers. He put in iberdomide, or does that sound like a drug to you guys?
Iberdomide.
Yeah, it's Limide. Okay. Anyone want to take that for $20 and about secondary cancers?
I don't think that we've had iberdomide around long enough to see a secondary cancer signal, at least not that I have heard of so far. The secondary cancer signal that we saw with Revlimid was really, really, really late in our use of Revlimid, and really came up during the maintenance studies that I had mentioned. I think the important thing about some of the secondary cancers associated with the immunomodulatory drugs is that compared their benefit, so the FDA looked at this, a lot of investigators looked at this, the benefit that those drugs give in the way of myeloma control versus the risk of secondary cancers. The risk of dying from myeloma and not having good control of the myeloma versus the risk of dying of a secondary cancer definitely weighed on the risk of dying from myeloma than dying from a secondary cancer, which is why we still use the IMiDs to this day as maintenance therapy. And there are actually studies that we are getting underway at Karmanos that are using iberdomide as maintenance therapy. So we may get a better idea. One little interesting point is that one thing we're beginning to notice is that there's something called clonal hematopoiesis, where all of us, as we get older, have little clones of mutated cells, not mutated myeloma cells, but mutated myeloid cells or blood production cells, and that may be more accentuated after those clones may be more accentuated, more active post-transplant. And it may be in some of the secondary cancers just aren't the drug causing secondary cancers, but that we have a little bit of predisposition that's accentuated a bit more with these drugs. So I wouldn't be afraid of maintenance therapy based on secondary cancers at all.
That's good. We have a well, listen, they want us to have an in-person meeting out here in Los Angeles and have both of you speak. So we'll try to get you out here for some Mexican food, Dr. Cole. Let's see, a dear friend of mine, Carlene, is it important to be restated after diagnosis of 20 years? I know this person, 20 years plus. She's asking if she should be restated at that point. Even, I don't know her personal care, but what do you think?
That's a really good question. I think that if the myeloma is beginning to progress, so if the myeloma is, and we'll again talk about relapsed myeloma in a bit, but if the myeloma is progressing, then it's not a bad idea. And we frequently will obtain bone marrow biopsies on progressing patients to see if the myeloma has acquired any new mutations or new cytogenetic lesions. Because sometimes patients at the time of diagnosis can have a 11-14 translocation, but then 20 years later, when they relapse, could develop a more high-risk lesion like a 17p or an addition of chromosome 1. Also, when someone's relapsing, to reassess the bone status. And so doing a PET scan to see what the disease is doing. So if someone is stable disease, if they are not having any symptoms of myeloma, then it's not necessary to restage them. But frequently when patients are at the time of relapse, we reassess where the disease is to see what the next steps would be in the way of treatment.
Here's a great question. I'm 57 years old. Heart and lungs are in good shape. 6 months past stem cell transplant. Will I get my stamina back to run marathons again?
Yes. Yeah.
Okay.
And so absolutely. So I think even in that graph that I showed, when they looked at patients who underwent a stem cell transplant, that they regained their functional status, if not just a smidge better than their functional status pre-transplant. And I have had patients who were a young person, because I call 57 young, just like you, and it took time. So it wasn't right away, but the more they worked at it, they got right back to the functional status, if not better.
Well, that's a good little word there, better. So listen, guys, let's take our break now. We're going to do a little stretch and mindful thing here that help you out. Take a break. Let's take this on, and then we'll have Dr. Kershaw and Sandra Rome come on. Thanks, everyone, so far. I appreciate it. Oh, my goodness, we're back, and I'm so relaxed. Everyone lift their arms above their heads and do the hokey pokey. There you go. Stretch and get your shoulders moving around, because sitting in one place can make you uncomfortable. So stay here, though. I don't want you to leave. Okay, now let's go on to the second half, the lightning round. Dr. Kershaw is going to talk about relapse therapy and clinical trials. We had a couple of questions, doctor, that said, how do I know to find clinical trials and stuff? So folks who would put that question in, you'll get an answer. Then we're going to, after that shortly, we're going to have Sandra Rome talk about how to manage myeloma symptoms and side effects, another good talk. So Dr. Kershaw, will you take it over from here?
Sure. Thank you, Kelly. And thank you everyone for joining us today. As you said, I'm going to talk about approaches to relapse multiple myeloma. I think one of the key things is myeloma is not one disease, but a spectrum of disease. And we do know that relapses occur and multiple relapses can occur, but fortunately we have many therapies now that we can employ along the way in the course of a patient's myeloma journey. So generally what we do see is the first remission is the longest, and after each subsequent relapse, the duration response seemed to be shorter. But I think with some of the new therapies, what we're partially also very excited about is we are now getting long remissions, even in patients in 5th, 6th lines of therapy. And so why is the disease different at each stage? Well, some of this is this idea of clonal evolution. So with the myeloma you start out with is not necessarily the myeloma you end up with. Patients acquire genomic abnormalities in their myeloma cells that can potentially make them more aggressive as the myeloma starts to come back. Sometimes it may be that one clone of myeloma is more sensitive to certain drugs versus another, so we are able to eradicate that clone, but a different clone subsequently resurfaces. And in part, because of this nature of multiple clones in a patient, we often use multiple drugs as treatment, both in the newly diagnosed setting, as you heard from Dr. Cole, but also in the relapse setting. So how do we think about treatment in the relapse setting? We certainly look at the age of a patient, but chronologic age is not really the issue. In fact, I was just on a panel 2 days ago for a CAR T-cell engager workshop, and that question came up. How do you evaluate patients for CAR T? How do you evaluate patients bispecific? And it's very clear now that, in fact, it's different criteria than what we use for autologous transplant, and age is really not a barrier to those therapies. More importantly, the things that we think about: comorbidities. Does someone have heart disease? Is someone diabetic? Does someone have bad neuropathy? What are people's blood counts? And when we think about some of these really novel therapies, such as CAR T-cell, we also need to think about lifestyle. Is someone able to stay near a CAR T center for up to 2 months? Does someone have a caregiver? Because we really cannot do CAR T without a caregiver, both during the early phase as well as when someone goes home. What about kidney function? Another key thing. Some of these trials, as you'll see, certainly in clinical trials, they tend to exclude people who have poor kidney function, but once the drugs get approved, and that includes CAR T, we have tended to use them in people with some degree of renal impairment. Then we look at people's disease itself. Is it something that myeloma that's progressing very quickly? Is it something that is a more indolent, what we call biochemical progression, where you're really just progressing on paper alone, right? The M spike goes up or the light chains go up. And then we look at what are the previous treatments you've had, and that can influence what are the next treatments we're going to give. So some of the bread and butter trials, and I wouldn't really focus on the actual trials, more the concept. So Dr. Cole already talked to you about daratumumab, the anti-CD38 monoclonal antibody, so immune therapy against myeloma. It is really the backbone of our treatment for patients in first relapse. Now, the challenge is this trial came out before we were using daratumumab in the newly diagnosed setting. So you have to say the field moves very quickly. But for patients who are not refractory to daratumumab, meaning their disease is not progressing while on daratumumab, we really very much quickly use daratumumab at that first relapse based on this trial, the Pollock study. You can see here in the Pollock study, daratumumab was given with lenalidomide and showed a marked improvement in progression-free survival. The challenge, I apologize that none of the background on these slides makes it a little confusing, but it's really the concept more that the gray line here is the daratumumab arm, and you can see it's certainly a big benefit over the just Lendex arm alone in terms of staying in remission and progression-free survival. Now, these are patients, though, who were not refractory to lenalidomide. In the United States, most patients are placed on lenalidomide as maintenance therapy. So when you have your first relapse, it's very likely that you're, in fact, refractory to lenalidomide. So in that case, our real backbone is pomalidomide instead. And based on this Apollo study here, you see daratumumab plus pomalidomide and Decadron. You see a 37% reduction in the risk of disease progression. The median progression-free survival was about 11 months. Now, of course, that's not the only combination. Dr. Cole talked to you about carfilzomib, another proteasome inhibitor, and I would say this is probably one of the most potent regimens we have in that early relapse setting in patients who are not refractory to daratumumab. A combination of daratumumab plus carfilzomib, and this was based on the Candor study. You can see when the Candor trial was done, the dara was IV, and the carfilzomib given twice a week at 56 per meter squared, which are important points as well. Same thing here. You see a marked improvement in progression-free survival with the carfilzomib arm, about 27 months, so pretty decent. The challenge is in patients over age 65, there was a higher rate of deaths, mostly due to infection. So I'm a little bit cautious about using it in older patients. But going back to my earlier points, looking at the type of relapse, someone with an aggressive relapse, I want to respond quick, I want to get a deep response quickly, I will tend to use this regimen. And the other thing you can see it seems to work even in patients with high-risk disease. Now, of course, daratumumab is not the only anti-CD38 antibody. We have isatuximab, another anti-CD38 antibody, same kind of idea. ISA plus carfilzomib. Carfilzomib is the same dose, 56 per meter squared. But ISA is actually given weekly for the first cycle and then every 2 weeks. You can see here, same idea, but better progression-free survival. In fact, the median PFS not reached in the ISA arm versus the carfilzomib arm. And again, consistent across subgroups, meaning high-risk disease, older patients, renal impairment, etc. So here's the kind of summary, and I have to thank my colleague and friend Nina Shaw for this slide. Basically, if you have relapsed myeloma, relapsing on lenalidomides, so lenalidomide refractory, but not daratumumab refractory, you have multiple choices. You have dara-pom-dex, you have carfilzomib-pom-dex, you have carfilzomib dara-dex, you have isatuximab, carfilzomib dex, and I should add in here, actually, you also have isatuximab pom-dex. So CD38, as she puts it, is like the Peloton. Everyone's doing it, everyone's using it, either newly diagnosed, or if you're not using it in the newly diagnosed setting, then you're certainly using it in that first relapse setting. But as Dr. Cole mentioned, now we're really using it in the first line. So what do we do if the myeloma comes back? Well, we're really lucky now. We have other options, with some of them being BCMA-based therapies. So BCMA is B-cell maturation antigen. It's expressed on the surface of malignant plasma cells and also expressed on the surface of B cells, which is important when we look at some of the side effects of these therapies. The first therapy we had approved was another antibody, but in this case, this antibody was attached to a warhead, or what we call a chemotherapy drug called mafedotin. And so the reason that it's attached is if you just gave someone IV mafedotin, they'd probably get pretty sick. But when you attach it to an antibody, that antibody can localize to the myeloma cell, attach to the myeloma cell, and then the mafedotin is delivered inside the myeloma cell. So you limit the toxicity of really killing the myeloma cell. So belantamab mafodotin was approved in advanced relapsed myeloma after 4 or more prior therapies, and usually the backbone therapies you can see, CD38 antibody, an immunomodulatory agent, and a proteasome inhibitor. It was based on the DREAM2 trial that it got approved, and these were patients with a median of 7 prior lines of therapy. Because of the side effects, though, of this drug, namely ocular toxicity seen in 71% of patients, the FDA allowed it only to be given through a REMS program, which requires an eye exam done at baseline and before each dose of the belantamab. And also a dose reduction, dose modifications for this. Overall, the response rate was 31% for belantamab. Now, the approval was contingent upon the phase 3 trial, the DREAM3 trial. And this is where it gets a little bit more confusing, because the DREAM3 high-level results were released, meaning that they released a progression-free survival results and overall survival results of the DREAM3 trial, which was belantamab mafodotin compared to pomalidomide and dexamethasone, and did not show a significant progression-free survival benefit. So it calls into question, since that trial failed to meet the endpoint, and that trial was part of the FDA mandate in regards to the belantamab approval, really what is going to be the next steps in regards to belantamab. Now let me switch gears to bispecific antibodies, because these are the newest kids on the block, and we had one approved in October. Bispecific antibodies are exactly that. They have 2 targets, one of them being the T cell, those immune cells in our blood, the other thing being the myeloma cell. And they can be attacked at multiple targets on the myeloma cell, and the ones we have right now are BCMA based, but we have also other targets, GPRC5D, a cell surface receptor that's also expressed on hair and nail follicles and hair and nails, so on keratinized tissue. FcRH5, a receptor expressed on B cells as well. So we have lots of different exciting options for our bispecific antibodies. What they stand in common is anytime you activate T cells, you're going to get cytokine release. So you get the flu, you're going to get cytokine release. That means fever, chills, as a natural body reaction. Now, the first and only bispecific right now that we have approved is teclistamab, one that targets BCMA, and it was approved based on the MajesTEC-1 study, a study in first in human patients with relapse refractory myeloma. Important to know, these patients could have not have had prior BCMA therapy. And you can see, why were we so excited? Median of 6 prior regimens, 63% response rate in these patients, and responses were quick and deep, with about a quarter of patients, in fact, getting to that deep MRD negative state. You've heard about MRD, and it's very exciting that we can get it even in advanced relapse disease. The important question has always been, how long are these responses going to last? And the median duration of response was about 18.4 months. So certainly very encouraging for us. The other thing that it bears watching is the fact that in terms of side effects, the majority, 72% of patients get cytokine release. And because of that, the FDA, when it approved the drug, required that the patients be observed inpatient for up to 48 hours post each dose during the step-up dosing. So we give step-up dosing, which is tiny little doses of the drug, to help reduce the severity of the cytokine release. And indeed, that seems to work, because you can see less than 1% of patients got grade 3 cytokine release, which is much more severe, requiring the use of medicines to support blood pressure or requiring higher flow of oxygen. So most patients get mild cytokine release. Generally, a fever is what we've seen. But the other things to look at are really, of course, most patients who get some degree of hematologic toxicity, so blood counts dropping. That tends to be fairly transient. It's not a cumulative thing, meaning every cycle. And we think some of that may be from the immune effects of these agents. But the important thing to look at is infections. And that's something we're recognizing more and more with these bispecifics, in part because they're given without an endpoint. So you know that as you deplete B cells, certainly patients become severely hypogamma, and we often replace IVIG to try and mitigate some of the infection risk. But still, we see in other types of infections, for example, COVID-19 clearly was a big challenge for patients on these studies. You can see 12 COVID-19 related deaths. Now, of course, some of that reflects the time when this study was ongoing, but certainly we've had patients who've gotten COVID now on this study who have certainly done much better, fortunately. But nonetheless, clearly we remain concerned about infection as a signal when we use these drugs, and appropriate prophylactic strategies are needed. For example, we use acyclovir prophylaxis, we will use Bactrim for PJP prophylaxis, and we will give IVIG to mitigate the hypogamma, the low immunoglobulins, to help reduce the risk of bacterial infections. There are multiple bispecific antibodies in study here. You can see I talked to you about these other targets. That's what the drug called talquetamab, we're very excited about, and those results are also out there. They all really generally have the same response rate, about 60% in patients who've had a lot of previous therapies, at least 6 prior lines of therapy. So patients who really advanced relapsed myeloma, over 50% of them can respond, and that's what makes these drugs so exciting. Talquetamab is the one I talked about that targets GPRC. GPRC is on keratinized tissue. That means your nails. It means the hair follicles as well. That's why it's fairly unique in some of the side effects we see. So same response rates I talked to you about, 69%. So that's really exciting. But let's look at side effects here. So again, that cytokine release, the fever, chills, in most patients. So they do the same thing. They give tiny doses, step up dosing first. But the unique things with talquetamab, it says something here called dysgeusia. That's a fancy way of saying taste changes. And that happens in a lot of patients. We're still trying to figure out why. Some patients say that everything tastes like cotton wool. Some patients say they can only taste sweet things. Other patients can't taste salty things. But this is certainly a problem. And, as I said, we're trying to figure out why. We certainly see a lot of dry mouths with this drug and sometimes difficulty swallowing. So certainly things that we do to try and help is things that can stimulate saliva flow. So sucking on sugar-free candies, drinking a lot of water, artificial saliva. But that still remains a challenge in terms of these taste changes. We see a lot of nail and skin changes as well. We've had people's nails get pitted. Some people have actually lost their fingernails. They do grow back, but it is certainly related to that target, that GPRC, 5D being expressed on those nails. And then the other common thing we see is skin rashes, tends to be peeling of the hands, palms, and soles. That usually is in the first treatment cycle. That's manageable. We give people steroid cream. We tell people to keep their hands very well moisturized. And again, that tends to get better. But it is something just to know about so that it's not alarming if it happens. And then this is another drug, cevostamab, different targets. I said, now we're so lucky. We have all these different targets on the myeloma cell. And sometimes we've had patients on these studies who've had one, it worked for a while, then stopped working, and then we put them on a different target. And that certainly has been the case with cevostamab. We've had patients on cevostamab who've relapsed after CAR T cells, for example. Cevostamab was the only study that just gave the drug for a year. So that was also pretty amazing that we had what we call a fixed duration. So we didn't keep saying, keep taking it, in perpetuity. Instead, we said, give it for a year and then we see what happens. And I can tell you, I have patients been off cevostamab for 2-3 years now who've remained in remission. You can see the response rates here about 53%. Side effects, again, that same thing you keep seeing, that cytokine release. And that is because you activate T cells, the immune cells in the body. You see this infection signal as well, something we need to watch for and try and prevent as much as we can. And then, of course, CAR T cells. We're very excited. Every patient I think I've seen has always asked about CAR T cells. The first one we had approved was in 2021. Ida-cell. The second one was in 2022, cilta-cel. And you can see now there's so many other ones coming down the pike. You don't need to memorize them just to know that there's a lot of other ones. We're trying to make CAR T cells better. We're trying to get what we call off-the-shelf CAR T cells, so we don't have to get them from each patient. Instead, we have a bank of T cells and we can just immediately just pull them out and get them ready for a patient. And here, just to show you the two trials, this is the KarMMa-1 study that was published in the New England Journal. And we're very excited because the response rate was about 73% with this drug. And we saw responses in older patients as well, patients with more advanced myeloma as well. Again, very exciting for us. Nonetheless, it has not been a cure, and you can see that patients do continue to be at risk for relapse. The other study we have is CARTITUDE. It's about the other CAR T product, 98% response rate in patients with a median of 6 prior lines of treatment. So again, patients with very advanced myeloma can respond to these therapies, and you can see here they live, meaning their long-term survival seems to be good. And they had a study comparing this CAR T cell to dealer's choice. What did they use in the real world if you couldn't get CAR T cell? And you can see here, clearly patients who got CAR T cell did better and they lived longer compared to other standard therapies. So that is the good news. Same kind of side effects that you see with those bispecifics, so specifically those cytokine release again. tends to occur at different times depending on which CAR T cell you get. But the other thing I wanted to mention is the neurologic toxicity, the toxicity that is still a big challenge for us. Some of it can be very quickly after the CAR Ts are infused. Patients can become confused, difficulty finding words, headaches, shaky, or it can occur actually 6 months afterwards, and that's even harder one to treat. The patients can get something like Parkinson's disease symptoms, tremors, difficulty of shuffling gait. And as I said, that is much more challenging to get for good therapies. For some reason, oops, let me just. But now the other challenge is in regards to, I've shown you the CAR T cells work in up to 90% of patients. We can get long remissions as well. Some of the challenges of CAR T cells are getting a CAR T cell. So this was a study of 20 centers that do CAR T, and you could see that we don't get a lot of spots. It's really not up to us. It's up, the companies allocate spots to each center, and somewhere between 0 to 4 spots, depending on the center. And so we have waiting lists, and the average time of patients on the wait list, you can see here, is 6 months. So that speaks to my earlier point. How do you pick a treatment for someone? You have to figure out how quickly is the myeloma progressing. If it's progressing really quickly, you probably can't wait 6 months to get that treatment. So part of the message, though, is that we're trying to get out to referring doctors is if you have someone with relapsed myeloma, refer them to a CAR T center early. They may not be ready for CAR T yet, but at least they get in the system, we're aware of them. And so that the point that they need it, hopefully, you know, they're already on the list, and that we're able to move quicker to get them the therapy that they so need. Lots of hard choices that we have to make. Who do you pick from the waiting list? Is it first come, first serve? Is it who has the most aggressive myeloma and needs it right now? Is it younger patients versus older patients? So really hard choices to make here. And different centers probably have different kind of assessments of that. So now the good news, we have multiple new therapies for relapsed myeloma, which can show very high response rates and long remissions. Bispecific T-cell engagers, which are the newest class of drugs to be improved, show a lot of promise and excitement. We need to manage the side effects well to make them as safe as possible for patients. And thank you, and I'll turn it back to Kelly.
I really love your talks. You know, you handle a couple of topics that are really difficult to understand. And I think that helps the patient. You know, as Craig said, 32 type of drugs are out there, plus the treatments, the CAR T slots, things like that. It's very complicated for a patient today. So I believe that you help them out, Dr. Kirshner.
Thank you, Kelly.
Let's see, Rob, do we have any questions? Let's go back to what I had here. Let's see. I had a couple. How long, this is going to be for both of you to answer. How long should Revlimid maintenance be continued? Is it something that's related to my numbers, or is it related to keeping my numbers down? That's the question.
I'll take that since that was kind of in my bucket. So right now we continue Revlimid maintenance and actually most drugs for until relapse. And it's not because we haven't looked. There was a study that tried to figure this out as part of that stamina trial that I mentioned, where patients post-transplant were on Rev maintenance, and they were given a choice of stopping Rev maintenance after 3 years or continuing on Rev maintenance. And interestingly enough, half, it was about 600 patients and 400 patients, and half of the patients decided to stop after 3 years. The other half decided to stay on. And at about soon after that 3-year mark, the patients who stopped Revlimid maintenance started to have relapses. Both groups were having some relapses, but definitely the group that were in the that stopped therapy early had more relapses, and that was and that kind of told us, one important thing was that at least 3 years we should continue it. Again, when you beat down the disease, this is a way to keep it down. There's studies that are looking at that if you're MRD negative, can you stop therapy early? And I think we still see some more results from those studies to really have MRD as a way to be able to tell if someone's in such a deep response, they need to continue their maintenance therapy. But the short answer is it's continued until the time of relapse.
And I've heard a lot of people over my years here that are still on that drug and are doing fine. So it seems like it's a good drug for what I understand.
Well, I do think two things. One,
Yes.
In the stamina trial, the 3 years was picked basically because that's how much the trial had funding for. At the end of that as the field moved so quickly, the other trials were coming out suggesting staying on Revlimid longer was beneficial. And so then the trial was amended to patients who were still on it to stay on it. Having said that, that was all comers. So it doesn't really have the nuances of individualizing treatment. And if you look at treatment in myeloma in Europe, they don't use Revlimid indefinitely. That's really very US based. We have a trial that's ongoing in the United States that is looking at, can you stop treatment? So patients are continuing on for 2 years. Then they have an assessment, that MRD assessment. That's where we look for 1 in a million myeloma cells. And then patients are randomized, meaning assigned. Some patients stop, some patients continue on the Revlimid. And that trial will really answer for us in a truly kind of fashion. If you get a really deep response, can you stop treatment?
Got it. All right. We have a question from Steve. Let me go to the first part. Sorry, I'm toggling here. I can't find it. All right. Using DARA in induction, does this limit availability of DARA for relapse? Given 32 new drugs, should we care? Don't we have a lot of bullets in the belt? I guess that's a Western reference there. So DARA in induction, talk to us about that.
There's been a couple interesting studies that have looked at investment of therapy and when do we hit the hardest and what benefit do we get? Meaning that the best chance that we have to knock the myeloma out for long periods of time is upfront, and that the investments on return in leaving drugs for later lines of therapy, like leaving DARA for relapse or a second or third relapse, is there's less return on the investment in leaving things for longer periods of time. So using DARA upfront and driving and getting those deeper responses upfront when the disease is the most sensitive works, I think, well. The other thing is that when DARA is used as maintenance therapy, it's not used as maintenance therapy indefinitely. So when, in the Griffin trial that, and I think a lot of people are doing is using the DARA for a few years, maybe 1 or 2 years as maintenance and then leaving the DARA off. When it usually takes, 5 or 6 years to relapse, then by the time that someone relapses, then you can, consider re-exposing them to daratumumab because they've been off therapy a while. And so the two answers to that question is that, I think that the studies, every study that's been done in the upfront setting that have compared DARA to non-DARA regimens. Basically, DARA's won all those fights in the upfront setting and really in the relapse setting. The second thing is that it's not continued on so that you can change to something else. And I think the important thing is there's so many new drugs that are coming out that, that why would we leave, DARA for a later line of therapy when there's so many good therapies at the time of relapse?
Excellent. Let's do one final question here. This is from George. We always review these charts. We always review these charts about Revlimid maintenance, chemotherapy live, and survive over 10 years or longer. Do you have, or have you given myeloma patients medication or treatment that cured under your algorithms, the patient? Anyone?
Yeah, I think one problem is that we don't have a good definition of cure in myeloma. And so, but if you apply and if you apply, cure as in, off therapy, no one off therapy and not receiving anything, and then having the disease, in a remission for 5 years, I think I don't have any patients yet that aren't on any therapy and been in remission 5 years. But if you modify that definition of cure and the disease has not been detectable for very, very, very long periods of time, absolutely. I think that we all have patients that have done extremely well, that have had responses that have lasted, very long periods of time. And that really speaks to the idea of multiple myelomas, that it'd be difficult to find two identical patients that have this disease. That the disease is very heterogeneous. And I've had patients that have lived, 20 plus years and on. And I've had patients that have lived very short periods of time because their disease has been that aggressive and refractory. And so, I think that the time that we're going to define a cure is probably coming soon as we have good therapies. But, I think, we've had patients that have had their disease at bay for very, very long periods of time. Yes, I can definitely point to patients that have had the disease at bay for very long periods of time.
Excellent. And one final thing here, EvuShield, does it still remain effective against newer COVID variants? What's your guys' opinion on that? Dr. Kirsten?
We certainly still give it. I think the data is evolving that it may not be as effective obviously as some of the newest variants out there, but we still are giving it.
Okay. Same with COVID shots, boosters, et cetera. You guys say it's okay for the patient to get that?
Well, those that, they are obviously newer, the bivalent vaccine, and we certainly do recommend that for patients.
Okay, good. Thank you, panel. That was really good. I want to go on to the next speaker here. Sandra Rome and I have worked together for a long time, and I find her talks to be very personal, very helpful, and helps you through successes in myeloma, good and bad. So let's take a breath. Let's sit back. Let's put our pencil down a little bit, and let's start with Sandra, who has a great presentation about how to manage myeloma symptoms and side effects. Many of you are going through this. Take it away, Sandra.
Thank you, Kelly. Thank you all for being here. I do want to say I'm at Cedars-Sinai in Los Angeles, but I actually grew up in Portland. So any of you Oregonians up there, welcome. And so we don't have a huge amount of time, but I am going to talk about some of the important side effects and how to manage them. So many of you may know that the side effects that you may have can be either from the myeloma treatment, from rapid and effective disease control, durable disease control, and minimum side effects are the goals. You want to allow for good quality of life and improved overall survival. And we also have supportive therapies that prevent side effects, optimize symptom management, which is important, and allow for good quality of life. So as you've listened to the physicians talk about all the different therapies that there are, these, your goals and side effects together, they're going to change over time. And so it's really important that you have that close relationship with your providers, with all of your healthcare team to make sure that we maximize not only your treatment, but we minimize the side effects and consider your goals as well. So an important point is to prepare for visits and even consider telemedicine. That is one of the good things I think that happened because of COVID. But come prepared, bring a list of all your medications, write down your questions and concerns. Have there been any changes or life changes or medical changes in your life and new symptoms? And I find that sometimes it's hard to remember everything, so jot it down. And you want to know what the next steps are, what the future appointments are. And I always tell patients that clinicians are only as good. We have our diagnostic tests, the lab tests, all those things, but you play a really important role in putting the puzzle together and finding out what's going on with you. And a big part of that, of course, is you telling your practitioners what's going on with you. So coming prepared is very important. And then is telemedicine an option? Oftentimes it is. So may require some process and technology setup. You may have to draw your labs for a day or two beforehand, so your clinician will have it. You want to have a quiet, well-fitting location and plan yourself, and have that all that information available so that you can have a robust conversation with your provider. I don't think that next slide, please. Okay, and I won't spend too much time on this, but of course, you have all your different treatment options from your MIBs, your MABs, your MIBs, steroids. We'll talk a bit about that. General chemotherapy, some of the new immunotherapies and cellular therapies, and they all, some of them have overlapping side effects, and some of them can compound the side effects together. But really, that's part of our job in making sure that we monitor and minimize these toxicities, that they're managed so that the treatment can be effective. So it's important that we all work together to make sure, again, that these treatments are not only effective, but that they maintain your health, really. Next slide. So auto transplant still remains one of the frontline treatments that we have. But there are no black and white answers. And so I think the physicians eloquently talked about how, age is not necessarily a no in terms of some of the aggressive therapies, either upfront or in a relapse setting, but really it remains a decision that you and your provider will make together in terms of your treatment, the best treatment at the best time. So understanding the process will help bring focus in terms of your initial plan and then maybe your long-term plan in terms of your treatment. Next slide. Care partner support is incredibly important, particularly for some of these treatments that require you to have somebody available to get you back to the medical center if you need to because of some of the toxicities. There may be maybe that they have your partner, your caregiver, in the process, in the discussions with you to make sure everybody is on the same page and that you will have the support you need. Caregivers may need to help with daily activities, helping manage the slew of medications, and continued support and assistance, transportation, etc. So, we as healthcare providers really make sure that we have all of those important features planned out in advance, so that, again, these treatments are given safely, that you're given the support you need. And if you don't have a wide range, or even narrow range of good support people, working with your healthcare team, social worker, etc., in getting that support you need, so that, again, we provide you with your treatment in a very safe and effective manner. Next slide, please. So patient-reported symptoms can be from a variety of things, and we throw the term around quality of life and what it is. And quality of life really is a general term that it means different things to different people. It can be and things that can impact that can be, of course, physical symptoms such as fatigue, constipation, pain, neuropathy, impaired physical functioning, sexual dysfunction, psychological, depression, anxiety, sleep disturbances, decreased cognitive function. Change in roles is often a big one for people, in terms of having to balance their normal life with their treatment plan. And then financial burden too is a big worry of a lot of people. Some of these drugs are very expensive. Healthcare or insurance programs have different ways of covering or not covering these. So again, that's where you can utilize your healthcare team, pharmacy, social worker, etc., and even some of the companies themselves have assistance programs to help reduce the burden. So again, all these things are important to us. And so you reporting your symptoms and how you're doing physically, emotionally, and financially is really important in terms of the success of your treatment. Next slide, please. So, of course, myeloma cells can cause symptoms, the myeloma itself. So we talked about hypercalcemia, renal dysfunction, anemia, bone pain, fatigue, infection, and other some unusual symptoms that can occur from myeloma, such as even some neuropathies, for example. And then the treatments themselves. The doctors talked a little bit about some of these, depending on the treatment, but certainly myelosuppression and immune suppression and infection, again, peripheral neuropathy, diarrhea, fatigue, clotting, deep vein thrombosis. So all of these things can contribute to how you're feeling. And so, again, you're a really important part of the puzzle in terms of making sure that we minimize these side effects and symptoms so that you can continue your treatment effectively. Next slide, please. So myeloma cells can cause damage to the bones. Dr. Cole went over that quite eloquently. And most patients will experience bone involvement at some point. So it's important to protect your bone health. So approximately 85% of myeloma patients have disease. So making sure that you do things to protect your bone health. So nutrition is important, weight-bearing activity, even medications, vitamin D or calcium, if approved by your doctor, and those bone-strengthening agents that were already discussed. So report any new pain to your healthcare provider. And then certainly exercise and nutrition are an important aspect of doing your part in terms of minimizing the risk of bone disease and fractures. So certainly have a discussion about mobility, exercise, and nutrition with your clinicians as well. Next slide. Kidney and renal function can also be a problem. And so Dr. Cole already discussed the light chains and different things that can happen to the kidneys. And certainly if you have diabetes, if you get dehydrated, you don't have good perfusion of your kidneys, that can lead to kidney problems. Some medications can, including even antibiotics or contrast dye. So that is why we monitor your labs, your creatinine, etc., and making sure that you protect your kidneys. So unless you're instructed otherwise, maintain really good hydration. If you take any over-the-counter medications, even make sure you let your practitioner know. For example, non-steroidal inflammatory drugs can affect the kidneys, so those are over-the-counter. And also maintaining your treatment is important in keeping your kidneys healthy. In some instances, patients do end up on dialysis, either temporarily or even long-term, and that doesn't necessarily preclude you from getting treatment. So, do your best to maintain your kidney function, but certainly treatments can continue if you do end up with some renal dysfunction. Next slide. There's our water. So steroids. I'm guessing a lot of you attending the symposium today have been on steroids. If you haven't, you're going to have an interesting discovery. So steroids are important, and the best way to describe steroids are their lympholytics. So we know people take steroids for asthma and things like that. They basically enhance the myeloma therapy. Steroids can cause people to have irritability or mood swings or depression. And so if steroids, if and when, which more than likely they will be part of your therapy, try to figure out, is it better to take it in the morning so that you are like the Energizer Bunny and have a lot of energy, or sometimes taking it at night and then that energy kicks in the morning. Taking it in the afternoon, however, sometimes makes people not able to sleep. So again, just finding out what schedule works for you, but make sure you discuss that with your practitioners. Take them with food because it causes some stomach discomfort. And then like some of the other therapies, it can contribute to an infection. So your provider may prescribe antiviral medications, etc. So again, the steroids, although they have side effects such as muscle weakness, they may increase your blood pressure, water retention, they may increase your blood sugar levels. They are very important as part of your treatment. So don't stop them unless you are directed to do so by your provider. Next slide. GI symptoms, a lot of these therapies can cause either diarrhea or constipation. So, and this is not something we like to share with everybody. So I think it can be quite embarrassing for patients, but it's very, very important. Diarrhea can be caused by medications and supplements, antibiotics, etc. And on the other hand, constipation can also be caused by by pain medicines, antidepressants, etc., from some supplements. So it's really a balancing act. And again, really important that you talk about your GI health with your practitioners. So there are things you can do to reduce those symptoms, such as for diarrhea, avoiding caffeinated, carbonated, or heavily sugared beverages. There are some over-the-counter medications that might be helpful. Again, checking with your practitioner about what might be best. And then for constipation, of course, there are additional things. So fluid intake can help with both diarrhea and constipation. And so again, the important thing is you don't want to get dehydrated, for example. And so these are symptoms that can be readily dealt with and improved. But again, it requires that you let us know how you're doing in this regard. Next slide. Peripheral neuropathy can feel like numbness, tingling, prickling sensation, sensitivity, touch. It can either be burning and cold, and actually it can actually be quite it can contribute to falls, for example. So it's very important that you notify your practitioner if you have any numbness or tingling or any symptoms of peripheral neuropathy. There are some things, and I think this highlights an important point in terms of all of the therapies and side effects that you may experience, is don't be afraid to share side effects with your practitioner. Think, oh, if I tell them, then they're going to stop my treatment, and then I'm not going to get my treatment for myeloma. And that is not true. There are some changes that they can make in your treatment, as well, of course, interventions that can be done. So there are a couple things that for neuropathy, like cocoa butter, vitamin B supplements, even some amino acids, and there may even be medications like Lyrica, for example. And also physical therapy might be helpful. And there are a variety of other medications that could be prescribed. So again, don't wait to report this side effect. Next slide. Pain can significantly compromise quality of life, and unfortunately, pain related to multiple myeloma can manifest itself in a variety of ways. Not all pain is equal. It can be from the bone disease. Bone pain is different from a neuropathic pain, or it could be from medical procedures. You want to make sure that you can prevent pain when possible, or let your practitioner know the type of pain that you have. Interventions depending on the source of pain. So they may have to do imaging to see what is the etiology of the pain. It could be a new lytic lesion, for example. But there are certainly a lot of things that can be done. Dr. Cole had mentioned some of surgery might be an intervention, maybe some kyphoplasty. There can be even acupuncture might be something that they might recommend for you. Maybe you do need some opioids, for example. But again, you want to really share that with your healthcare provider, because you don't want to necessarily take over-the-counter medications, like I mentioned, the NSAIDs, other things that could not be good for you. So again, sharing with your healthcare provider what kind of pain, what is the onset, etc., what exacerbates it, how does it affect your functioning. Pain is not managed well. It really not only affects your quality of life, but it affects your ability to be mobile, to maintain your bone strength. And then, of course, you're at risk, again, for weakness. Steroids can can cause upper thigh weakness too, and it can spiral down from there. So really, again, my main message is, make sure that you talk to your healthcare provider so that we can help you with good pain management, and we can maintain your mobility and your safety and your comfort. Next slide. Fatigue, anxiety, and depression can all affect the quality of life and relationships. And fatigue is the most common reported symptom, actually not even just with myeloma, with cancer in general. And it can be from a physiologic phenomena. Maybe you've got anemia, maybe you have a pain, maybe you're not sleeping well. It could be from some of the treatments, or maybe you have had fevers and that kind of thing. That is very fatiguing. Maybe you have some anxiety, or maybe you're depressed. Again, we talked about the emotional burden of myeloma and its treatment, and the changing trajectory of your treatment over time. And so it's important that you share these symptoms, share how you're doing. I think sometimes patients want to always give us a happy face, be the good patient, but know that we are here for you, not only to treat your myeloma, but to help you as a person. So please make sure that we address that. Next slide. And then we already talked a little bit about COVID and as well as the potential immune suppression of the myeloma itself. Some patients can be hypogammaglobulinemic. Some of the treatments can make your white blood cell count go down. Some treatments lead you at risk for viral infections, including the COVID-19 infections. So it's important that you keep up with your vaccinations as directed by your healthcare provider, and really just good hygiene, good hand hygiene. Wear a mask when out in public. I think a lot of healthcare providers, I know we still do that because COVID is still out there. Again, hand washing is the most important thing for all of us in terms of reducing infection, and good hygiene in general, good oral hygiene, etc. Next slide, please. And so healthful living, I think I'm going to wrap up soon here on time, is managing stress. So, you know, we talked a little bit about quality of life and emotional health and all those things, but really how each of us manages stress is different. So again, whatever you find is helpful for you, make sure that you incorporate that. And don't let myeloma and its treatment really stop you from doing some of the things you love if you can, and managing stress. The things you can do to maintain a healthful life. Again, nutrition, activity, and exercise. So if you were never an exercise person, but now might be the time to make sure that you again incorporate some kind of activity to maintain your mobility and your safety. Preventive health care is important. Even though, you know, you're dealing with myeloma, you still need to have your regular health screenings, your regular vaccinations as indicated. You want to have good health habits, so stop smoking if you're a smoker, dental care. You want to maintain your renal health. We talked about making sure that you maintain your hydration and that you avoid really toxic medications. So be a little bit more prudent about not taking over-the-counter medications unless you check with your myeloma provider. And then again, we talked about nutrition, activity, your bone strengthening agents that your physician will recommend for you. So an ounce of prevention is worth a pound of cure. And really, we talked about how long you can live with this disease. And we want you to live well, not just survive. Next slide. And so the fact that you're all here today, I'm guessing you've had a chance to look at the wonderful IMF website. They have webinars, they have all these brochures, and I really think that they have the info line, but all of the new updates you can find. So there's a lot of things always that are on the internet, but I think, I hope that you look to the IMF for the most reputable and up-to-date information on current therapies, new therapies, and ways to really live your best with myeloma. So I think that's my last slide.
Wow.
You are not alone.
I love your talk.
Thanks.
It's really good.
Kelly.
And I like the color wheel, and I like that you spend some time on the emotions and the psychological warfare, I guess, you have to go through with this. So thank you, Sandra. We do have a couple of questions. Second opinion telemedicine consultation. Sir, I want to send you to the IMF at 800-452-CURE, which is 2873. 9 to 4, our info line's open, and I think that they have some people that can help you out there. Here's one that warms my heart. I'm 83 years old and had myeloma for 10 years. Multiple prior treatments, including Revlimid, Velcade, and Laro. Now on Dara for 5 weeks as a sole treatment for 2 years is what it's been suggested. my abnormal protein went from 2.8 to 0.3. Can DARA be stopped for a time? I know it's a personal one, but what's your guys' thought about daratumumab? Anyone?
We kind of recommend staying. So let me back up. Do I, any of my patients that are on this know that that when patients when they're responding well to therapy, that for events, they go on vacation. I had a patient that went to Greece. Did he take his daratumumab with him to Greece? No, he didn't. We gave him some time off therapy, and so we have people, take vacations for vacations. But can we stop it indefinitely? And so not be on any therapy, especially when the protein's still going down. We kind of want to get that best response out of it. So I would stay on. If there are toxicities, and I would definitely think about changing therapies or stopping. But usually we try to stay on. I mean, the biology of multiple myeloma is definitely a chronic disease kind of biology, that they're in the same way that you can't, and in general, that you can't stop your diabetes medication. I can't stop my blood pressure medication, or else my blood pressure will just bounce back up. I would love to take a shot that would have my blood pressure stay stable indefinitely. But I have to take it every day to maintain it. And that's what we have to do with a lot of myeloma therapies.
Fantastic answer. And I've been paying attention to my blood pressure. My doctor says it takes the pressure off the pipes, whatever that means, but it does. I'm better for it. So listen, let me read this one. Let's see, we have, okay. Untraditional treatments such as acupuncture or herbal medicines or any of that kind of stuff. I know that green tea is not good for some of the drugs. What drugs are those that aren't good for green tea, please? If you're drinking green tea, you shouldn't be on something. Is it Velcade or something? I remember some of that would, like grapefruit juice and green tea, have a problem with some of the drugs. Is that true? Does that happen to patients?
In reality, you'd have to drink gallons of green tea to really have a significant difference. So, I don't think people need to over-index on that. In regards to integrated medicine, I mean, we are very lucky. We actually have one of the national experts in integrative medicine at City of Hope. And he has a lot of incredibly exciting stuff in regards to an acupuncture trial. He has a trial that's going to open soon about using lavender, which has some anti-anxiolytic properties in it, before bone marrow biopsies. So certainly we are very on board in terms of using integrated medicine in a fashion in conjunction with traditional medicine, I think is the key thing. So not doing it sort of without your physician knowing.
Sure. That would be the bad part.
I agree. And then a lot of big centers do have like cancer rehab centers. So again, they can help not only with physical functioning, but with cognitive type of improvement and those kinds of things. So if your center doesn't have that, they could perhaps refer you to a center that does.
Okay, good. We have a food question. I'll just finish it with this. I can't stand spinach and salad, especially hard to eat. I'm trying to do things for my body, eat healthy, so forth is very hard. I go with what my body will tolerate, usually bagels and eggs. And I do take an anti-nausea pill for that. Talk to me about taste, anyone. Is this something that's definitely going to have, do you warn the patient to be paying attention to this problem? Anyone?
Do one of the doctors want to take this, or do you want me to?
Oh, go ahead, Sandra.
I think it's different for everybody. And again, it depends on your treatment too. So I would say, answering the first thing about if you like bagels and eggs and don't really like salads or any kind of that, well, that's where talking to your doctor and even a dietitian, because there are other ways to get healthy calories in you. I know some people, they want to go straight to Jamba Juice, which is nice, but it really probably doesn't have a lot of protein, for example. So I'm not a registered dietitian, but certainly you can be referred to a dietitian to if you don't like green salads, then they can maximize your vitamin intake through other means, perhaps, that you would tolerate better. So again, utilize your interdisciplinary team in terms of the questions you might have, to make sure that, again, you're not just eating, food that you hate all the time and you're miserable, but that there are foods that you love and that you can tolerate, but that are also healthy for you.
Yeah, they say I guess they don't eat the food that you like because you'll hate it after. What were you going to say, Craig?
With my wife being a dietitian, I have to, she would bounce to the door and knock me in the head if I didn't say. She wouldn't do that, but if I didn't mention how important seeing a dietitian is, because there are lots of the therapies. Myeloma itself changes your metabolism. The treatments that we use changes your metabolism. Definitely the DEX can wreak havoc with a lot of different things, and so. The way that I met my wife, the dietitian, is I was referring my patients to a registered dietitian, and she's the smartest person I know. So,
I'll agree with that. Good job, Craig. I was going to say that your wife's a nutritionist or blah blah, that, and I'm glad you brought it up. Any other following comments that you guys want to make before we draw to a close here? Oh, I have one other comment. Saute the spinach and mix with your eggs, he says. Well, anonymous attendee, I hope that helps you out. And Steve, I appreciate your comments all the time. So this part right here is something that comes from my heart. I thank all of you for doing this for us and doing it at the IMF. I know a Saturday is a special day, and you took some of your time from that day to help us out. You helped out a lot of patients today, and that's what's important to me. Have a great weekend. Have a great holiday, and enjoy yourself. And for you guys out here, we want to take the time to thank our sponsors again. I know I've said it a couple times, but they're incredibly important to our program. We got AbbVie, who just started with us, Karyopharm, Amgen, GSK, Bristol-Myers Squibb, and Janssen, and Takeda, and you are all been participating in some of the products that they offer. So keep an eye on these drug companies. They'll might have some things that you'll understand that you can pass on to your doctors or nutritionists or your nurse. And the IMF needs your feedback. You'll get it at the close of this meeting. You'll also be notified when some people said, can you go back to a slide on particular decks? I can't do that, but you can go to the slide deck and review it. And if you have questions, you would call our info line at 800-452-CURE. So next slide is what we're doing. We are done. As a follow-up to the workshop, we'll have the speaker slides and video replay, as I've said 3 times. And I want to thank everyone that participated in the workshop. We are grateful, and myeloma.org or 800-452-CURE is how you get to these booklets, get to our programs, get to the newsletter, sign up for all presentations that you can, and you'll see that they are all geared towards the patient, because you're the most important person of the IMF. Thank you very much. We'll see you soon.
Happy Thanksgiving.
Happy Thanksgiving.
Thanks, guys.